Hello and welcome to Nursing Emergencies Pulmonary Edema. This is part of our Nursing Emergencies program, and I hope you will join us for the rest of the Nursing Emergencies program. So let's talk a little bit about pulmonary edema and the etiologies for pulmonary edema. I think a lot of times when we think of pulmonary edema, what usually goes through my mind is I'm thinking about that situation with a patient who has heart failure and has fluid overload. Well, that is one type. That is the hydrostatic type. So what occurs with heart failure is we have a backup of fluid. The fluid backs up into the lungs, and now there's too much pressure in that pulmonary vasculature, which then pushes fluid out into the pulmonary tissue, and we get pulmonary edema. Another way to get pulmonary edema, though, is osmotic. So we have a solute that's pulling water from the area of higher concentration, which in this case would be in the tissue of the lung, from the area of lower concentration, which would be the vasculature. So it's pulling water out and into those pulmonary tissues. The primary electrolyte imbalance that can cause this to happen would be a sodium imbalance. So if their patient has a low sodium level in the bloodstream, that means the sodium level in the tissue is higher than it is in the bloodstream, and it's going to pull fluid out of the vasculature and into the tissues and cause pulmonary edema. Another type of pulmonary edema, and one in which we're seeing a lot more of lately, is called permeability type. This happens with sepsis, systemic inflammatory response, ARDS. All of those kind of conditions will cause inflammation to occur in the lung. Inflammation causes capillary permeability. So we end up having fluid leaking out of the capillaries into the tissue and causing pulmonary edema. So let's take a look here at what's going on. If we're looking at the alveolus, we're looking at the vasculature, and where this fluid is coming from and going. Our fluid is in the vasculature there, and so we have our fluid moving out of the vasculature into the interstitial space. So you notice on this diagram, it's showing that there is a space between the alveolus and the vessel. And that's actually true. There is a tiny little microscopic space between the alveolus and the vasculature. One of the reasons for this, there's a little bit of fluid in there that lubricates it, because remember, the alveolus is expanding and contracting as the patient takes breaths in. And if it did that continuously and rubbed up against the vasculature, we would have inflammation there all the time. So there's a little bit of fluid in that space, in that interstitial space. However, what happens with pulmonary edema is that fluid leaves the vasculature, moves into that interstitial space first, then it moves into the alveolus. Now, we can catch this in its early stages when fluid is just moving into that interstitial space by looking at a PO2 FiO2 ratio. So that's why those numbers, those pieces are put there, is so that you can understand what we're looking at when we talk about a PO2 FiO2 ratio. We're looking at the ratio between the PO2, the amount of oxygen in the blood, and the FiO2, the amount of oxygen that is delivered to the alveolus. If this alveolar capillary membrane is working well, then the FiO2 should be transmitted. It should move across that membrane and get into the bloodstream to become PO2. So we can take a look at that, and simply it's just a mathematical equation. You take the PO2, you divide it by the FiO2. Okay, the FiO2 is put into a decimal instead of a percentage. So most of the time when we talk about FiO2, we're talking about percentage, like 50% or 21%. And in this case, now we're going to move that into a decimal, so 0.5 or 0.21. And so we're going to divide our PO2 by that number, and we're looking for a number that's greater than 300. If the number is less than 200, then we really are looking at a patient who probably is having some problems with that alveolar capillary membrane. So that's just kind of an early way of looking at the interstitial space and how well that alveolar capillary membrane is working. However, what if you don't have a blood gas available to be able to see the PO2? In that case, then we can be looking for the subtle signs of an increase in respiratory rate associated with subjective dyspnea. The patient is going to feel like they're having trouble breathing because they are in fact having trouble getting oxygen across that alveolar capillary membrane. So on presentation, we expect to see volume overload, positive INO, increase in the patient's weight, maybe some jugular venous distension, an increase in respiratory rate with subjective dyspnea. Remember, those are the early signs that we're getting fluid in that alveolar capillary membrane. Rales, so you start listening to the patient's lungs. We expect to hear the rales in those places where the lungs are dependent. So otherwise known as crackles too. In some institutions we call them crackles, and some we call them rales. So depending upon what the terminology is in your hospital, you might call them one or the other. Taking a look at the picture on the right here, you can see what's happening is that we're starting to get fluid building up, and as that fluid starts building up, going through that alveolar capillary membrane, working its way into the alveoli become less effective because they're getting filled up with fluid, and eventually this can lead to hemodynamic collapse. So our prompt action will be, we want to try to keep that fluid away from the heart. Remember, there's three ways that this can happen. We can have the hydrostatic type, the one we normally associate with pulmonary edema, which is from heart failure. We could have it be osmotic, or we can have it be the result of capillary permeability. In any case, we want to try to do the best job we can at modifying the preload, decreasing the preload. The preload is the volume of blood coming to the heart. If we can decrease the amount of volume coming to the heart, there will be less volume going to the lung that can be causing pulmonary edema. So even this is caused by capillary permeability. We want to be careful. Remember, in sepsis, one of the ways we treat sepsis, septic shock, is by giving fluids. The more fluids we give, the more fluid that the lung has to be able to move across into that interstitial space and cause pulmonary edema. Improving cardiac output. So if we can improve the cardiac output, hopefully we'll have less backup of fluid into the lung, and then hopefully we will decrease the amount of pulmonary edema. And then afterload modification. So we can decrease the amount of pressure that the heart has to pump against. So this would be the vasculature. If we can decrease the amount of back pressure, then we don't have as much pressure going back and increasing the pressures in the heart, in the lungs, and causing more pulmonary edema to occur. So watch for pulmonary edema. Look for those subtle signs of the increase in respiratory rate and subjective dyspnea, and then let's optimize the hemodynamics so hopefully we can decrease pulmonary edema as much as possible. Well, thank you for joining me for Nursing Emergencies Pulmonary Edema. Let's keep going in this series and learn more about managing our pulmonary emergencies. Thanks for joining me. Until next time.